Great. It's a challenge having in Egypt, in Cairo, meetings together with Professor Hesham, and it's always late, always full packed, but so interesting, and I appreciate very much. And the table here, appreciate very much that you are here following. We have try to make it short. There's three lectures or three presentations. The first is introduction and discussion about the RAS testing and consequences about this without a case, but for discussion, and then it's followed by the topic of peritoneal metastases by a case presentation, and the last one is the question of maintenance versus no maintenance, an important question for daily routine, which comes at the end. The first speaker is Professor Mohsen Mokhtar. He will give us some standards and views on the RAS testing.
Thank you, Dr. Small, for your introduction. I'd like to thank Hisham for inviting me and for everyone who's bearing with us till such a late hour. What I'm trying to do is focus on the RAS testing and how we're going about the RAS testing, and I think it's the only test that we are really developed with in colorectal cancer till to date. So we're beating around several ways of dealing with this RAS testing and what we should really be doing. So these are the things that I'm going to go through. What is RAS actually? Should or must we do RAS testing? How essential is extended RAS testing? What tests do we have? And how important is planning the continuum of care for RAS testing for the planning of continuum of care? When should we do the test accordingly? And what evidence do we have to support the patient's benefit when we do such a test? Because you do know, as you all know, it is quite costly, but also the drugs and consequences of this test are also quite costly. So the EGFR receptor, as you all know, has extracellular domain and is composed of 4 subdomains designed in 1, 2, 3, and 4 levels. And what it does is that when there is dimerization, there's the PI3 kinase pathway, and then there's the GRB, or the growth receptor binding 2 protein, and this will activate what's known as SOS1. SOS1 is responsible for the transformation from the RAS GDP into RAS GTP, and when this happens, then you go on to the pathway of the RAF pathway and the BRAF and whatever else goes. Now, the wild type is different from the mutant in that in the wild type there's only a short transformation from the GDP to the from the GDP to the GTP. That means that because of the increased GTPase, with the mutant type you don't have this, and that's why probably these mutant subgroups will not be affected by the anti-epidermal growth factor receptor targeted therapy. You have several exons that you can have mutations in, whether in the KRAS, whether in the NRAS, or whether in the BRAF. So, from this, I'd like to ask the panel, should or must we do a RAS testing? Can I go for Dr. Duyar? Would you like to answer this? How essential is it to have the extended RAS, and should or must we do a KRAS testing for our patients?
Well, from my point of view, the genotypic analysis should be part of the characterization of the tumor, as well as histology and a full workup, because this will finally be responsible for fragmentation of colorectal cancer according to the extension as described in the ESMO grouping, but also from a molecular point of view. And we know that roughly 40 to 50% of patients will have one of these RAS mutation, and for this high percentage of patients, the use of anti-EGFR will be excluded. And we know also that the RAS mutation occurs early at the sequence of polyp to cancer transformation. It is quite stable, so even if we don't want to use the anti-EGFR immediately, it's good to know for later second or third line use whether the patient is a RAS wild type or not.
All right. So the guidelines for this is that we do need KRAS and NRAS mutation analysis. The BRAF mutation analysis should be considered only if you have a KRAS mutation that is negative, and it is for prognostic. Further genetic characterization is continuing for colorectal cancer disease. Now, Dr. Schmoll, what else are we having in the future that is coming in as genetic characterization for colorectal cancer?
Beyond the RAS and BRAF, it's HER2, which very soon. HER2 overexpression.
HER2 overexpression. All right. So I think that's something that we wait for. Now, you mentioned BRAF. Now, does BRAF, how important is testing BRAF, and does it affect your clinical decision, Dr. Nasr? BRAF, how important is it to test it initially, and does it affect your clinical decision when taking decisions, whether with epidermal growth factor receptor, anti-epidermal growth factor receptor, whether with vascular endothelial growth factor or chemotherapy? Does it affect any of your decisions?
BRAF, in my opinion, carries a prognostic value rather than a predictive value. So it's related to the disease process and not to my choice of treatment. But at the same time, I should be rather choosing the aggressive form or the doublet or triplet chemotherapy. Yes.
Exactly that, because you can see that whether your patient received anti-epidermal growth factor or not in a BRAF mutated and he was KRAS mutated, you can see that in both groups, and both, whether it's overall survival, whether it is progression-free survival, overall response rate, patients with BRAF mutation always do worse than patients who have BRAF wild type. And as Professor Nasr said, these patients, you can see them, data coming out of the COIN trial, show you that in all of these patients, if they do not have any mutation, this is their survival, and if they do have a BRAF mutation, you can see this is the dark blue here, it is always worse in terms of survival. So the KRAS testing, the role of the medical oncologist should be, or should ask in a multidisciplinary team, it should be tested out very early, as Professor Duyar was saying. The automatic testing reflex by pathologists should be there, and the role of the primary pathologist is to select which tumor cells that are that should be tested, or which subgroup of the tumor should be tested for this. How difficult is it, Professor Duyar, to choose which subgroup of tumor or clones to test for the BRAF or for the KRAS for the mutations? Or can I just test any of them? Or is it difficult to choose which clones?
At the present time, it is difficult to select a given clone. What we do is a general approach. What is important is to have enough tumor cells, and the delineation by the pathologist of an area with as many as possible tumor cells is very important, because if there is a contamination with normal cells, of course, the probability of finding a KRAS mutation is higher.
And how confident are you in all the tests that have been going on? I mean, are we now getting more confident than we were 2 years ago, or are we at the same step?
I think at least in Europe, where there is a quality control network that has been organized, we have seen lots of progress in concordance of results between labs, because we were on the learning curves for both the pathologist and the molecular biologist, but things are really improving now.
Dr. Gamal, are we at the same level here in Egypt for the KRAS testing?
Sorry?
Are we at the same level? Are we as confident with our results in our region in Egypt with the KRAS testing, or do we still doubt?
We need some time to standardize our labs, yeah.
Okay. I know that a lot of our tests are being sent out to Europe for testing, and I think maybe one day we'll get them here. Now, the BRAF, as you mentioned, Professor Nasr, I think it has obviously prognostic scoring or a prognostic value, but I think also it may indicate that these patients should receive the most aggressive therapy as first line, or because this is probably their only chance for receiving proper therapy rather than subsequent lines, and not preparing them for longer continuum of care as patients who are BRAF mutant. So the NCCN guidelines, tests for KRAS, NRAS, BRAF should be performed. There is no specific methodology that is recommended. They have several recommendations. Tests can be performed on the paraffin-embedded tissue. Both primary and all metastasis can be tested. There is no proven discordance between the primary or the metastasis. And as Professor Duyar said, it occurs early on, so even if you haven't tested in the original specimen, maybe if you need to test when the patient becomes metastatic, you can do that, and they probably are the same, or if you've done, you don't need to test it again. So what tests do we have? Dr. Small, what tests do you think are the best tests that we have in the market for these patients?
I'm not the best underside. I think, Jean-Yves, could you comment this? What is in the network regarded as the best test?
First of all, there are many technologies available, from the old Sanger sequencing all the way to the new generation sequences. The problem is to set a cutoff.
Yes.
Because the latest technology, like the beaming technology, for example, is a lot more sensitive. But if you have 0.1% sensitivity, what is the meaning of this very rare
yes.
and low frequency mutation?
Yes.
If this means that 99% of the rest of the tumor is wild type, we may expect an efficacy of the anti-EGFR. So it's nice to find mutation, but they don't have all the same weight in terms of resistance to anti-EGFR.
And are we trying to put a cutoff point for the percentage of mutation that we can start treating with anti-EGFR rather than not treating with anti-EGFR?
I think this is presently studied because more and more labs are getting equipped with new generation sequences, but they are still in the learning period of the technology, and in most of the institutes in France, for example, they run their usual Sanger-based sequencing in parallel to the new generation sequencing, and they do cross-method comparison, and they will finally agree probably on a cutoff level to kind of standardize.
But till now, even if I find a few percentage of mutation in the guidelines, not to use anti-EGFR.
Well, it's really difficult to say. It's really difficult to say. If you consider the data from Opus, for example, they have presented initially data where they were using a very low cutoff value, and their incidence of less frequent mutation was much higher.
Yes.
And then they have reanalyzed the outcome by changing the level of sensitivity. And of course, if the cutoff value is no longer 0.1 but 1, they seem to increase the efficacy of anti-EGFR. Because again, this patient with a very low incidence and frequency of this mutation could still benefit from anti-EGFR.
Okay. How important, Dr. Nasr, is cost in all of this? You can see that we have costs running from 200 euros to somewhere like 250 euros. I think this is very reasonable cost for testing, and especially when you're going to know that you can save a lot of money if giving the patient the proper treatment. Now, the other question that I wanted to ask is what accepted or how long an expected date do you, Dr. Ola, would you think that your patient or your RAS testing should come in how long do you think we should take?
Okay, so we do it here in Egypt, and it usually takes around a week, a whole working week to get the results.
So we're within, obviously, the 10 working days that it has, that we are in Europe. And I think it's very important that the surgeons, the pathologists, and us as oncologists run off to do the test as early as possible to get this 10 working days. So, Dr. Alaa, how important is this RAS testing for the planning of the continuum of care of your patient, and when do you personally ask for the testing? In the beginning, or after first line, after second line, third line?
Well, how essential, it's quite essential. It goes without saying. I mean, it's determining my treatment and whether to give or not to give a certain type of biologics. And usually we do that at the first instance of metastatic disease, whether MIE, the novo metastatic, or after a patient has been treated with
Would you do it for a patient that is on the adjuvant setting? Would you do the testing and wait and have the results so they're ready when he becomes metastatic?
Well, I don't have a consensus on that, but sometimes you do that. I mean, especially on maybe locally advanced or high-risk patients, you should do that.
Okay. And so you said it is very important for the continuum of care of these patients, because as you can see, for all the audience, we are having data coming in very frequently. We've just had CRAMs approved, or ramucirumab approved for colorectal cancer this year. You can see that we're getting more and more drugs. How are we going to put them in the continuum of care? I think it is very important that we do these tests for our patients. These are the data coming out of the bevacizumab trial. You can see that obviously Bev plus any of the fluoropyrimidines does give you a benefit in progression-free survival, maybe in some of the cases in terms of overall survival. Looking at the patients with KRAS wild type, the data from the Crystal, Prime, and COIN all point out that they do benefit. Your patients will benefit from this targeted therapy, whether this is the more recent data coming out of the FIRE3 trial, Bev versus cetuximab in plus FOLFIRI for metastatic colorectal cancer, KRAS wild type, and I think what they did show in the KRAS wild type that there was a benefit for the cetuximab, but I think what they more importantly was when they did the whole RAS mutation, you can see that there is a real difference, and that's why you really need to do the full RAS testing, whether it is KRAS or NRAS testing before you give these therapies. Again, this is the SWOG trial, FOLFOX or FOLFIRI plus Beva, comparing it to the same versus cetuximab in terms of overall survival, and as you can see in this population, the same here, but if you look again in the wild type, there was some benefit. Looking at the quality of life of these patients, what I wanted to show you is that with these therapies, there is some decrease in the quality of life with the use of anti-EGFRs, and that's why you really have to know that there is a benefit for the patient before you start using them, and I think that is by proper testing for your patient. So this is the RAS implication for what you can see, unresectable metastatic colorectal cancer coming out of the FIRE3 trial and the SWOG trial, that there is an advantage when tumor burden is large concern. There may be an advantage of using anti-EGFR to bevacizumab, but this again is only to be done in patients that are full wild type. So what evidence do we have to support the patient's benefit? What I wanted to show you is what evidence we have against not using them or using them when the patient is not a full wild type. We know that both of the anti-EGFR, whether cetuximab or panitumumab, are monoclonal antibodies. You can see that in the wild type, the KRAS wild type, whether cetuximab or panitumumab, first line, second line, or third line, they do work for these patients. And you can see the prime analysis from the prime, especially in the non-mutated. This is, if you can see that there is a mutation here, you can see that giving FOLFOX to your patient alone or giving chemotherapy alone to the patient is rather beneficial if you have a mutated patient rather than giving it to him when he is a mutated patient. So you're giving more harm by giving this patient while he's mutated. Now, this is, if you were looking at resectability, this is just published a couple of days ago. Professor Dior, would you like to comment on this impact of early shrinkage in the coming out of the PRIME trial a couple of days ago?
Yeah, this is basically what I discussed earlier this morning that was just published in the European Journal of Cancer, this effect on early tumor shrinkage and deepness of response that we see with anti-EGFR, and it is important to consider essentially for a patient with group 1 and group 2 from the ESMO classification, the one that we would like to send to a conversion surgery, not after more than 6 or 7 cycles of chemotherapy because of the normal liver damage, or the group 2 patient with lots of symptoms or very risky tumors, and this is an additional point that has to be brought to the credit of the anti-EGFR.
So I think what I wanted to come out of this trial is that it is very important to do it very early on, even if I'm considering resection, especially if I'm considering resection, and it is very important to have it in a couple of days, as you said, not more than 10 working days, so we can get on with the therapy for our patient. Now, I think this is questions to the audience. You have your voting. Let's put the questions to the audience after what we've just said. Everyone has their voting. To the panel? Sorry. All right. So, to the panel. First question. Should or question? No. All right. Let's get the panel to show a hand. Should or must do it here? All right. So it's a must to do for the RAS test. Next question, please. Do we have a preferred test for any of this? No. So the panel agrees that we do have several tests, but nothing is till now considered as a preferred test. Next, please. Is this, in planning the continuum of care, very important, equivocal, or not important? KRAS testing. No, RAS testing.
It's a difficult question. It's not easy to answer.
It's not easy to
I would
answer.
not.
All right, so it's not important. Did you vote for that, Dr. Small? That it's not important? Okay, next question, please.
Just to
Yes.
say this. Continuum of care, what is this? We have to use all drugs in every patient as much as possible, as long as applicable and payable, affordable. It's independent of the testing.
Yes.
RAS testing is independent of this. If
All
you
right.
use cetuximab, whatever, then you have to do RAS testing. So it's a different question. So it's difficult to answer if you have two questions in one answer,
All right.
in one question.
Would you like to clarify?
No, it's
you
okay. I
comment?
think everybody understands.
I think it is important, because I do not agree with you. Because
What is important?
to know whether a patient is wild type or mutant in terms of building up a continuum of care.
I agree completely.
Because, there's no data on that, and we need to run more clinical trials, but we probably all have experience of patients who have received an anti-EGFR in first line, then BEV in second line, and we can reintroduce the anti-EGFR in third line, and in some time it works again.
Are we getting more anti-EGFR therapies that are coming down the track as terms of in phase 1 trials, phase 2 trials that are promising?
Not that I know.
Okay.
Not that I know.
Right. When should we test? Early, before second line, before third line? Yeah, in metastatic.